Good afternoon and welcome to this session on delivering at local levels, impact and relevance of localizing disease burden. And I am Prasada. I'm the moderator of this session. Before I introduce the main speaker, the presenter and the discussants, let me briefly introduce myself. I'm currently a member of the Independent Advisory Committee of IHME on GBD, which is chaired by Peter Payot. And I'm greatly honored for moderating this session on impact and relevance of localizing disease burden. Formerly, I was the Permanent Secretary of Health in Government of India, and later on, I worked in UNAIDS as a Regional Director for Asia Pacific. And for the last 5 years, I was working as the Special Envoy of the UN Secretary General on AIDS for Asia Pacific. So that's my introduction. Now, the impact and relevance of localizing disease burden is very topical for us, because while the GBD study reports are very strong in their technical content and usefulness to researchers, their relevance to inform policy, commitment of resources and programmatic interventions, especially at the local level, is becoming increasingly clear now and increasingly important. I won't make any of my comments at this stage, and I will reserve them to the end of the session, but I would be introducing our distinguished panel, the presenter and the discussants in a few minutes. First of all, our presenter today is Dr. Duncan Selbie. Prior to joining Public Health England on its formation in 2013, Duncan was Chief Executive of Brighton and Sussex University Hospitals, the regional teaching hospital for the southeast of England. From 2003 to 2007, he was the Director General of Programs and Performance for the National Health Service, and subsequently the first Director General of Commissioning. Prior to this, he was Chief Executive of Southeast London Strategic Health Authority, and prior to that, Chief Executive of the Southwest London and St. George's Mental Health NHS Trust. He joined the NHS on 1st January 1980. The discussants are, first we have Jeffrey Duchin, I think I pronounced it correctly. Prior to assuming the role of Interim Health Officer in August 2014, and later confirmed as Health Officer in June 2015 for Public Health, Seattle and King Country, Dr. Duchin served for 15 years as Chief of the Public Health's Communicable Disease Epidemiology and Immunization Section. He trained as a medical epidemiologist in the Centers for Disease Control and Prevention Epidemic Intelligence Service, after which he completed the CDC's Preventive Medicine Residency Program. He worked for the CDC, the National Center for Infectious Diseases, the Division of Tuberculosis Elimination, and the Division of HIV/AIDS Prevention before joining Public Health, Seattle and King Country. Dr. Duchin performed his internal medicine training in Thomas Jefferson University Hospital at Philadelphia, completed a fellowship in general internal medicine and emergency medicine at the Hospital of the University of Pennsylvania, and did his infectious disease subspecialty training at the University of Washington. He is a fellow of the American College of Physicians and the Infectious Disease Society of America, and holds appointments as Professor of Medicine, Division of Infectious Diseases, and Adjunct Professor in the School of Public Health at the University of Washington. Our second discussant is Laura Dwyer-Lindgren. She is from researcher at IHME, working with the US Country Performance Research Team and on the malaria control policy assessment. Her research focuses on small area estimation. In the US, she is working on estimating key risk factors such as physical activity, obesity, smoking, and alcohol use at the county level. As part of the malaria control policy assessment, she is developing methods for combining small area models with demographic techniques for analyzing birth history data in order to estimate under 5 mortality for districts in Zambia and subregions in Uganda. Ms. Dwyer-Lindgren was previously a post-bachelor fellow and member of the Demographics, Mortality and Population Research team at IHME, where she participated in estimating under 5 and adult mortality for all countries as part of the GBD study 2010. Our third discussant is Professor Liang Xiaofeng. He is the Deputy Director General of the Chinese Center for Disease Control Program. He earned his medical degree at Shanxi Medical University in 1984. He worked as staff of Gansu Health Bureau. Between 1993 and 95, he obtained a Master's of Public Health from the College of Public Health of Peking University of Medicine. He was an exchange scholar in the Department of Psychiatry and Behavioral Sciences, College of Medicine, University of Miami, Florida. In 2011, he became a Deputy Director of China CDC. He was the winner of the Wu Zipeng Paul Janssen Medicine and Pharmacy Award 2013 and rewarded as a middle-aged outstanding contribution expert of Ministry of Health China in 2011-2012. He received a special allowance subsidized by State Council of China in 2010. From 2008 to 2014, he was a member of the Global Strategy Advisory Group of Experts on Immunization of WHO. He served as the Vice Secretary General of the Chinese Foundation of Hepatitis Prevention. He was a member of the Chinese Advisory Committee of Immunization Practice, Chinese Association of Community Health and the Branch of Biological Products, Chinese Association of Preventive Medicine. He was a member of the National Polio Eradication Certification Committee and a member of the National Measles Elimination Verification Committee. And the last discussant is Maria de Fatima Marinho de Souza. She is the national of Brazil. She obtained her degree in medicine from the Federal University of Rio de Janeiro and then completed her medical residency, a Master of Public Health, and a doctorate in preventive medicine and epidemiology at the University of Sao Paulo. Dr. Marinho was a fellow student at the University of Quebec. She worked at the University of Sao Paulo, Faculty of Medicine as a medicine researcher from 1997 to 2003, when she was relocated to the Brazilian Ministry of Health as coordinator of epidemiology analysis. Dr. Marinho was responsible for the vital statistics systems in Brazil and the project for its improvement. In 2008, she moved to Washington, D.C. to work at the Pan American Health Organization, PAHO, coordinating the Information and Health Analysis Project. Since 2012, she has served as an advisor for the Regional Health Observatory at PAHO. In 2014, she returned to Brazil to work at the Ministry of Health in Brazil. That is the introduction of our speaker and the discussants. Now I would request our main presenter, Dr. Duncan Selbie, to make his presentation. Over.
Good afternoon, everyone. Do you think the lights could be turned up so we can see each other? Or more that I can see you? Would that be possible? Maybe it will happen in a moment. Thank you. So I'm not a doctor. I've been a chief executive of 5 different organizations in health in 21 years. And I'm the founding chief executive of Public Health England, which, whilst England has a very great history in being concerned with public health, it's the first time that we've had a single body charged with first protecting and then improving the health of the people, and crucially to address inequalities. We have about 5,500 staff, 2,500 of them are scientists in infectious disease and other hazards, air quality, radiation, this sort of thing. And we have people working in every conceivable discipline in public health, focusing on improving the health of the people. Now, when I first met Chris Murray, is Chris still in the room? It was like I dialed into heaven. And so I've been with the health service in the UK for almost 40 years. And as Professor Rao said, I worked in the Department of Health, and I've also led an acute teaching hospital. So for the 10-year period before I took up this responsibility, I was point contact for the Health Secretary and for Downing Street about health policy, as well as then for 5 years trying to implement it in a hospital. And not once in those very intensive years when I was in the Department of Health did we have a conversation about public health. The conversation was all about what was happening in the NHS, which is the healthcare system in the UK. And we talked about hospital-based activity, and we talked about money, and we talked about hospital-acquired infection, and we had the same conversation for 10 years. And in the UK, and I think it is the same in many parts of the world, certainly in the middle and high-income countries, but in the UK, we conflate good health with further and greater investment in the health service, and that we believe that the more that we invest in healthcare, the better the health of our people. And what the global burden of disease did, just as I was taking up post, was give me a broader understanding, if you like, a scientific basis on which to question that narrative. And we've published extensively using the GBD data in the UK context to talk about healthcare as a contributor, of course, to good health. By this I mean the GBD definitions of length of life and life in good health. That about 10% of that is the contribution of healthcare. About 40% early avoidable deaths, ill health when alive, that are amenable to an intervention. And the remainder are socioeconomic and environmental. In other words, conflating good health with further and greater investment in healthcare is not going to improve the health of our people. Now, that was not a conversation that I'd had in the Department of Health or in my previous 30 years in the health service. So if it's not about healthcare, what is it about? And the narrative that we are developing using the global burden of disease, which tells us what the diseases are that our people are dying from, combined with understanding the risk factors. The diseases in the UK, people are dying from cardiovascular disease, cancer, dementia, and the risk factors are the same, whether it's cardiovascular disease, cancer, or dementia, whether you smoke, how much you drink, what you eat, whether you exercise, and hypertension. It takes you so far, but what it doesn't do is tell you why that might be and what you can do about it. So when I was in the early stages of setting up Public Health England, I should say it brought together over 100 different organisations into one. I was before Parliament, the House of Commons, and the politicians were asking me what were my priorities. This was 6 months into the role. And I can't tell you how grateful I was to Chris and to the global burden of disease, that I was able to say I have two ways of choosing my priorities. I look at the global burden of disease, which tells me what the diseases and risks are, and I look at the social determinants. Many of you will know of Michael Marmot's work, which looks at why that might be and what you can do. And I take those two magical sources, and out of that fall my priorities. And in 2014, we set 7 priorities for improving, protecting, and improving the public's health, directly from the GBD and from the social determinants work. I want to focus particularly on 2 of those, and then talk about how we've developed the GBD and how we use this in England and what we're doing today. And then I want to talk about what the next number of years might look like. So in 2013, we had the benefit of the first proper GBD report. It was launched in London. in December 2012, I recall. And then in 2015, we published subnational data for the 9 regions of England, but also data for Scotland, for Wales, and for Northern Ireland. And this year, we have the data, but we won't publish it, I think, until next year, early next year, is the data, the GBD data at upper tier local authority level. This is the level at which most decisions get taken in England, 152 upper tier local authorities. So if I think about tobacco, in England, we've just published the lowest prevalence rates for smoking ever. And it's the second lowest prevalence rates in Europe. And just in the last 12 months, we have 500,000 fewer smokers in England, just in the last year. I think a number of factors affecting that, but e-cigarettes being one. But the point is the GBD allowed us to re-energize what had probably got a bit tired. We've had 50 years of action in the UK to reduce tobacco use. But what the GBD did was say, do you know, whatever you've done for the last 50 years, it's been really important, but it's still the biggest killer. It still takes away 1 in 2 people early, and for every person who dies early, 20 others have a tobacco-related disease. And it's allowed us to tell that story, but also to put it into an economic context, that 500,000 admissions into NHS beds, into hospitals every year are for tobacco-related illness. So we're able to use the GBD and other sources of data that we have, not only to show what the prevalence rate is, but with the GBD at subnational level and what will become very, very local data, is to show the differences and variations between one part of the country and another. And we've not been able to do that. We've not been able to do that before. So the people who live in the northeast of England have improved the most in reducing smoking, but still have the highest rate of tobacco-related prevalence. And the difference between Bradford in the north and Guildford in the south is by a factor of about 3. So we're able to use the GBD that says tobacco remains the biggest killer. You might have spent a huge amount of time and effort, you've made a huge difference, but it still is killing your people, and it's taking them away early, and it's costing you a huge amount in treating disease. Also up there is obesity. 2/3 of our adults are overweight or obese, and our children between the ages of 5 and 11, one in 4 5-year-olds who are overweight or obese becomes 1 in 3 by the time they're aged 11. What happens between the ages of 5 and 11? And if you are at the poor end, if you are at the opposite end of affluence, your chances of being overweight at age 11 are doubled. And we can show a very local level, at school level, how many children are overweight and where we need to pay attention. Now this also involves national action. Again, inspired by our understanding of the data, where government can pay attention. So we have introduced a sugar tax, comes into legislation next year, and it's an incentivized tax that if you can take the sugar out of the drink, then you won't get taxed. So we are changing behaviour in the sugary drinks industry by motivating them to take the sugar out. Point I'm trying to convey is that if we're concerned with improving health, we need to recognise that length of life is hugely important, and it continues to improve in the UK. It is slowing down, but we've just the data for men is the best yet. But we have to be more concerned with keeping people well, and how we keep people well and address the burden of disease, not just what the length of life is, but the burden of disease when alive is where our focus is. So when we think into the next stage for the global burden of disease, we're thinking about the three priorities: how we keep people well for longer, how we keep them well and in work for longer. In the UK, about 100 billion, these are people in work, about 100 billion of costs through people who are in a job but unwell. A third of that, about 35 billion of that cost, is associated with two main causes: musculoskeletal disease, the joint pain, and depression. So we're using the data to say to the government, to local government, and to the NHS that if we can pay more attention to people who have a job but are out of work because they're unwell, that we can improve the economic performance of the country. We can help people to stay well for longer and to stay in the workforce for longer. Secondly, we're looking at air quality and about how we can work with local areas using the data to work on improving air quality in those parts of the country that are suffering the most, having the burden of disease with the consequences of respiratory disease and this sort of thing. And we're focusing on cardiovascular disease, which continues to represent about a quarter of the burden of ill health. So, in England, what we're seeking to do is to use the GBD data to shift the narrative, to give us a framework for how we prioritize, where we focus, the choices we make. We've never had that before, and the focus has always been on healthcare, and it is shifting, and it's shifting from a conversation about public health to the public's health, whatever it takes to improve the public's health. That healthcare is important in that, but much more important is about how we help people, whether affluent or poor, about the choices they make, about the risks that they face, all beautifully articulated in the GBD. But also widening it again to saying this is really a question of the economy, and to have a thriving economy, you need to have a healthy people, and at the heart of that is to have people in work, and clearly improving work and decent work. But we want people to improve the health of people. We need to get people working, and we need to help people to stay in work when they're unwell. So today I can say, whether it's to the Health Secretary or into Downing Street, in Parliament, local authority level, to the NHS, directly to the public, that health is wealth, that having the argument about why all this matters is important but not sufficient. What the GBD does is help us to win that argument. And that's the strength. It can't on its own succeed in that. It has to be balanced with the wider understanding about the causes of the causes and what you can do about it. But if you take the GBD and you take social determinants, you have a narrative that talks to health, which is about wealth, which is about the economy. And as a public health system, that's our agenda. This is not owned by public health professionals or scientists. It needs to be owned by people that look more like me. I think I look like Sean Connery. Do you know Sean Connery? So I have the accent, he has the looks. But it needs to be owned by people like me, because it's people like me that are in the room having the conversation with the policymakers and the politicians. It isn't sufficient to have the evidence. You also have to have the consent of the people, which is why this is all about politics. Thank you for listening.
Thank you. In fact, UK is one of the first countries which have gone for subnational estimates, and it's nice to hear from Dr. Selbie what are the experience of UK. Maybe we'll bring it out during the Q&A if you want to know a little more about it. Now, coming to our discussants, first I would like to request Professor Xiaofeng to make his presentation in 10 minutes.
Okay, thank you. Good afternoon, everyone. Firstly, I would like to take this opportunity to congratulate the 20th anniversary of the GBD and thank IHME for inviting me to this important session to share China's as a collaborator of the GBD. China CDC has worked very closely with the IHME since then 1995. Since then, and both parties jointly organized evidence-based policy dialogues. China and the GBD in 2013, and China burden of disease study worked in 2015. At the meeting in 2015, China CDC officially established the China Burden of Disease Study Collaboration Center, witnessed by Dr. Chris Murray and Richard Houghton. The establishment of the China Burden of Disease Study Collaboration Center has been an important step towards a much stronger connection between China CDC and higher level leadership from IHME and the University of Washington. The president of the University of Washington, Mrs. Kaus, just visited my center last month. Tomorrow we will sign a new MOU for the futures collaboration. And the new secretary of the IHS of the United States just visited my country, and his topic is the sharing the data. He also visited China CDC. So we have made great progress localizing the estimation of the disease burden in China. One is that we use the GBD estimation to provide evidence to the lawmaker, especially on banning smoking in the public places. Second one, we submit the policy report on the China Burden of the Disease Study to the National Health and Family Planning Commission. And also we distributed the provincial profile of GBD estimation to each provinces. And also we have many publications in both English and Chinese version. And also we invite many experts from IHME to conduct a training course in China. Another important area is to carry out some research based on the GBD methods and the estimation. We have carried out a burden of disease study at city level. We predict the burden disease of China in 2030. We have incorporated the GBD method to China Cardiovascular Health Index study. And we started studying on influencing factors and intervention strategies of health in Chinese population. Among all this, the burden of disease study at city level is an important working area in collaboration center this year. At the first phase, we indicate 5 provinces with 82 cities and estimated life expectancy and health life expectancy, mortality, yield, and daily from 2005 to 2015 in each of the cities. We are expecting to include more provinces in next phase. At the policy level, we provide data support for the Health China 2030 planning and predict the burden of the disease of China in 2030. Based on our prediction, only 9 provinces can achieve 30% reduction of the premature mortality in NCDs by 2030. So that's a big challenge for Chinese people and the government. One more work, we have been putting efforts in the setup of burden of disease analysis platform and the big data applications. January 2017, China NCD Data Alliance was established, and one city in the Hubei province's Yichang NCD Data Study Base was established. This city visited just by the Alan Lopez. A burden of disease study will be conducted in Yichang City using the data from the platform. We organized the public health and big data application workshop with the participation of the many Chinese experts and WHO and the US CDC, pushing forward the utilization and the application of the platform. China CDC has put the burden of disease study and the development of the burden disease collaboration center as a priority in our numerous working agenda. We are pleased to see the progress we have made so far. We also have more expectation on the GBD. So in our next step, we will carry out the burden of disease study at the county level in China. So that's how to, we have almost 3,000 county. How to train this staff is our challenge. And I also want to conduct the carry out J.V.R's practical 5 by 5 kilometers analysis of the NCD and the risk factors in China. And we want to evaluate Health China 2030 and the SDG of China. Also, we want to explore the application of big data in GBD study. And also, we want to further localize the GBD estimation. We have confidence that we have this good relationship with the IHME and continually to build up this capacity in China CDC and will provide important scientific support to health policy development in China. Once again, I have to say congratulations on GBD's 20th anniversary. Thank you very much.
Thank you, Dr. Xiaofeng. 3,000 counties, subnational data. I think, Chris, your hands are full for the next 5 years. Thank you very much. So over to you, Dr. Marinho.
Good afternoon, everyone. It's a great honor to be here during this commemoration, celebration of the CBD anniversary. And I want to talk in a perspective of health service. I'm not academic, okay? I work at the Ministry of Health of Brazil. And Brazil engaged in GBD not exactly since the beginning, but a few years ago. And we have a national network that we have some strategy. The Ministry of Health is funding the network. And we are coordinating this process at the same time that what we see in GBD, we saw opportunity to improve our analysis at the same time that we are doing our work that is improving data and information. In a population perspective, I can't wait for have a good data and good information so I would deliver good analysis and so I can do something. So in this perspective, I need to deliver healthcare, health promotion, health policy, and I need some guidance, at least for us, because we stay in the technical level, no? And we deal with politicians and politics, and it's different. If you put this perspective in the results of GBD, so when we advocate for priorities, when we show results, we deal with a political decision. What we call decision makers, they usually are politicians. They not exactly understand, it's not because they don't understand, I need to translate. No, it's not this. It's because they have other ideas. They have other priorities. All politicians want to be reelected. So what they have to do? No, not exactly what the data or the analysis is saying, but we deal with this. So it's a kind of a game that we play in a government. And connect this reality in the federal level, government level, to local level where the problems are, because health problems are local. They don't occur in the federal level or state level. They are at local, with the population, communities, indigenous, black people, poor people, slums, rural. It's where the problems are. And connect this and show that, look, we need to go to this direction. We need to allocate more resources here, or we need to allocate more health services. It's a kind of strengths and a kind of a game that we play all the time, convincing to allocate money, convincing to allocate more resources. No, because I can have impact here. If I do this, I can drop mortality, I can promote health, I can drop costs in the future. That is our reality in a concrete country, because Brazil is the fourth largest country in the world, and 210 million inhabitants, almost 6,000 municipalities. Our health system is public health system, and is based in municipalities. When it was done in the 20 years ago, like GBD, and was that time thinking that we have to base the system where the problems are. But the problem is, local level, we have to build the capacity there. If you don't build the capacity, how can they recognize the problem? Sometimes we go to the mayors. Mayors are much more sensible for problems because problems knock the door of the mayor all the time and the population is there. But see, if you don't have the human capacities built at local level, it will not work well. Some mayors will go there and show the problem. They say, oh, by now I didn't have any problem. Now you are showing that I have a problem. But no, my problem is that I need a hospital here. And you say, no, it's not cost-effective hospital here. No, we have another proposal. But you have other municipalities that we could go together and support one hospital for all. Because I cannot put one hospital in small population, but they want a hospital because politicians want something that people can see. So hospital is very good, because it's a building, so everyone see it. But no one will see health promotion. No, and the fight with what is rational, what is not more political, that is the result is the health care or the health policy. And for us, the main strategy is empower population, invest in human resource, communities, translate not for politicians, but translate for population. If they understand, they will fight for their rights. So that is the strategy, the key process. While we stay at the first at the mean level, or at federal level, ministry level, from there, we try to empower population. GBG is good for this. If I deliver, if I have local analysis, local knowledge, we can go to empower population. And the population empowered is the most powerful that we could get that move this. Reduce inequalities, fight for the rights, because some politics, it maybe choose more better politicians, because where the situation is worse, poverty, lack of capacity, politicians are the worst too. So there are correlation, in poverty and worse health, and bad politicians. So that's why the population, they are informed, have higher education level. I believe the education is key in this strategy. We could empower more. And that's the way that we move this world, not just one country, but we have to move together. More and more, you can see nowadays what is going on in many countries. So if we move together, as humans being, we could move this world para a best life. We cannot talk just about problems in one country, like I cannot talk just about a problem in one municipality, because they are all connected. All the problems are connected, and they have similar determinants. If you don't focus on this, it's social determinants. If you don't focus in power population, they know more about what's going on. We cannot change this world. You cannot improve it. And it's not a waste of time to talk to economists or politicians, but we have to keep this advocacy. But at the same time, we need more analysis. Knowledge is important for doing this, for empowerment. It's empowerment, people. Like said John Lennon, power to the people. So thank you.
Thank you, Maria. I think you brought in the community pressure. I think it was a very important issue. And thank you very much for that. And now.
Thank you. We recently had the privilege to collaborate with IHME on a census tract level small area estimation of the variation in life expectancy and mortality by 152 causes here in King County, Washington. And our report was published earlier this month in Lancet Public Health, and we believe it's the first systematic look at this small area estimate across a county in the US. This really represented a tremendous opportunity for our team, and I want to thank IHME for the opportunity to both collaborate on that study and to share some of my reflections about the work and its implications. If I run out of time, I want to just say I agree with everything Maria said. She really hit all the important points. For those of you who aren't from the area, King County is the 13th largest in the United States. Our population is 2.1 million. We're larger than 15 other US states. And we have a very ethnically and culturally diverse population. There are 140 languages spoken in the Seattle School District, for example. The knowledge of place-based disparities has long guided the public health efforts in our department towards areas with increased opportunities for improvement. And therefore, we're extremely interested in ways we can do this better. And it's fair to say that the recent analysis provided us with improved precision with which we can understand the causes and patterns of mortality in King County. I'll just share a few of the main or key findings from my perspective. Although the average life expectancy in King County is in the 95th percentile across all counties in the US, the analysis at the census tract level showed us an 18-year discrepancy in life expectancy for men and a 14-year discrepancy for women in different areas of the county. And the leading causes of years of life lost were also the leading contributors to health disparities across the geographic regions. And many of the causes of death followed similar geographic patterns to life expectancy. We did find a few spatial patterns that were unexplained and unusual, and we're not sure how to interpret those at this point, and I'll say more about that in a few minutes. My most important takeaways from the report were well characterized by Laura in the discussion, in that the disparities in life expectancy overall were not driven by any single cause, but resulted from the sum of disparities across a wide range of health conditions, and that the common geographic pattern across multiple causes of death suggests the role of underlying common determinants, such as the social determinants of health. So I want to spend a few minutes talking about some of the challenges and future directions for us as a local health jurisdiction trying to use this type of data. We certainly identified a number of potential benefits for this type of information, but it's really clear to us that the science and capacity around small area estimate reports and the resources available to produce this work are much more developed than the ability at the local health department level to use and interpret and act on the information. We don't have ongoing resources or capacity to continue the collaboration, for example, with IHME, and it was only through a grant from the de Beaumont Foundation that we were able to establish the initial collaboration, which in fact was intended not only to look at causes of mortality, but also morbidity, years of life lost from non-fatal conditions. But we ran out of money before we could do that part of the grant, and we ran out of money before we could do some of the validation using some of our direct estimates that was also desired. So not having resources for ongoing collaboration is a problem for me, and one of my personal priorities is trying to identify ways to continue this type of collaboration and make it sustainable so that we can effectively interpret and use these results optimally. We certainly have work to do with respect to this type of analysis and educating our workforce and our stakeholders on the methods, the reliability of the results, the optimal ways to display data and the boundaries between geographic units, for example, the impact that outliers have on visualizations, and whether results represent true spatial variation or non-sampling error. Some of our priorities, if we were able to do additional work, would be to include other outcomes such as socioeconomic status, risk factors, racism, toxic stress. If we can incorporate administrative data such as healthcare utilization, insurance status, and behavioral health indicators into the analyses, and understand the impact of rapidly changing demographics in some of our neighborhoods. I think from my perspective, the bottom line is that we're stuck with the quandary of how to most effectively use these types of data to improve health in our community, to influence policies and programs. For example, given what we know now based on this report about the causes of years of life lost from various conditions, it would be great to understand what interventions would yield us the greatest benefits. For example, we would love to be able to compare the years of life lost that would be averted by different strategies across our region by neighborhood level. So with that, I'm going to turn the mic over to Laura, who is our key collaborator on this project. And again, thank you very much for the opportunity to do the work.
Good afternoon. I'm going to start similar to Jeff and state that I agree with everything that's been said thus far. I'll probably repeat some of it in the context of talking about our US research. So I'm a researcher at IHME. I've been involved in the GBD in some capacity since 2009. And for the past 3 or 4 years, I've had the opportunity to participate in our subnational research in the US, particularly related to counties. So people who are not intimately familiar with US data, and actually even some who are often surprised to find that there's relatively little comparable, comprehensive information about health outcomes at the county level in the US, and really even at the state level for that matter. And that's not to say that this information doesn't exist. There are many states and many counties, including Washington and King County, that do a pretty amazing job collecting and analyzing and utilizing data on the health of their populations. But this is being done on a state-by-state or county-by-county basis, and so it's difficult to compare across different areas. And particularly when you start thinking about the county level, most counties are relatively small. They're served by small public health departments that, in my opinion, are often dramatically under-resourced. And they don't necessarily have the capacity to do large-scale descriptive analyses similar to the GBD. So what we've been trying to do is to fill some of those gaps and produce estimates at the county level for the whole of the US that are comparable between different areas, and at the same time to pretty dramatically expand the scope of what's available in terms of different health outcomes that are being measured. So specifically, borrowing from the framework of the GBD, we've estimated all-cause mortality, life expectancy, and cause-specific mortality for all of the causes in the GBD hierarchy on an annual basis from 1980 to 2014 for each and every one of the 3,142 counties in the US. So what I'd like to do with this talk is to present just a few of the findings, primarily as a mechanism for illustrating why I think that this is a really useful and important thing to do, and then talk a little bit about what are the factors that make this type of analysis possible and also where we'd like to take it in the future. So by far the most consistent result to come out of this analysis is that there's a truly massive amount of variation in health in the US among different regions and different counties. For example, we find that life expectancy varies by 20 years between the county with the lowest life expectancy and the county with the highest life expectancy. And we also find that that gap has been growing for the better part of 30 years. When we look at mortality rates by cause, we again consistently find huge variation, and not just in the actual level of mortality, but also the magnitude and sometimes even the direction of change in mortality rates over time. Again, as an example, cardiovascular diseases are the leading cause of death in the US as a whole, and they're also the leading cause of death in more than 97% of counties. But despite being an objectively big problem everywhere, the actual magnitude of that problem in terms of the number and the rate of people dying varies massively. We identified counties where the mortality rate was less than half of the national rate, and also counties where the mortality rate was more than twice the national rate. For many counties, or for many causes rather, we also identified diverging trends in mortality rates. So for example, if you consider intentional injuries, so suicide and homicide together, about half of counties saw a decline in the mortality rate between 1980 and 2014, while the other half saw an increase. And this is true of a number of causes. We identify counties where mortality rates increased next door to counties where mortality rates decreased for neurological disorders, for chronic respiratory diseases, for cirrhosis, and for a large number of other causes. And then even in cases where all counties are headed in the same direction, they're usually not going in that direction at the same rate. Mental and substance use disorders are a good example of this. So driven in large part by the increase in deaths due to opioids, the mortality rate from mental and substance use disorders as a group nearly doubled at the national level between 1980 and 2014, and similarly increased in pretty much every county. However, while the increase for the country as a whole was a little bit less than 200%, we identify a substantial number of counties where the increase exceeded 1,000%. So what I'm trying to highlight with these examples is what I see as the relevance of this information. Measuring something on such a fine scale is really only a worthwhile thing to do if you actually think there's variation on that scale. Otherwise, it takes a lot of effort for not very much output. But in the US and at the county level, there's just no shortages of these types of disparities. And I'd also like to point out that while I have focused on disparities among counties in the country as a whole, we also find significant disparities among counties within individual states. So a particularly extreme example is cirrhosis, where the county with the highest mortality rate and the county with the lowest mortality rate in the country are actually both located in one state. And while that's not generally the case, we do consistently see big differences in many states for most causes. And that motivates why we want to do this at the county level and not at the state level, because there's meaningful variation among counties that you don't see if you're looking just at the state level. And then finally, the last thing I want to point out with regards to the findings, and this is probably not obvious since I haven't shown any maps, is that spatial patterns that we see differ by cause in some cases. So some causes are similar, especially ones that have similar underlying risk factors. But the spatial patterns for other causes are totally different. And that, to me, highlights the reason why we want to look at all causes and not just look at summary measures like life expectancy. Just because a county does really well or really poorly on a health outcome does not necessarily mean the same for all other health outcomes. And so this level of granularity, not just in terms of geography, but also in terms of cause, is really valuable when it comes to identifying the particular challenges and the particular opportunities for a specific community. I'd like to switch gears slightly to just briefly discuss what I see as some of the factors that enable this type of analysis. And I'm interested in that because I think that this type of analysis is doable in a lot of different places, not just in the US. So the single most important factor in my mind, and this is something that's come up a couple of times today and yesterday in the earlier talks, is that appropriate underlying data exist. So in the US, death registration is complete. It covers all areas, and conveniently from my perspective, it's compiled into one single data set at the federal level that happens to contain county identifiers. We do quite a lot of modeling on this data in order to extract the fullest value from it, but the fact remains that without these underlying data at the county level, we would not be able to do this type of analysis. A second related factor is that these data are accessible. Data that exist but aren't accessible to researchers aren't useful for research. It's not especially easy or definitely not quick to gain access to these data in the US, but ultimately there's a process in place that does allow researchers to do these kind of analyses. And finally, from my perspective, working alongside people who are intimately familiar with the underlying data is critical. Every data set has its quirks, and collaborating with people who know these quirks makes it possible to do a good job. I'd like to take one final minute to describe the future directions that we would like to take this work, contingent on identifying funding for it. And I'm talking again specifically in the US context, though I want to emphasize that I think this is possible in other places as well. So the direction I think that we're the most excited to potentially take this work, and Jeff alluded to this as well, is to expand beyond fatal outcomes to non-fatal health outcomes. From my perspective, one of the greatest innovations of the GBD has been to consider both fatal and non-fatal outcomes. I think 20 years of data coming out of the GBD have demonstrated the utility and importance of doing so. So that's one of our highest priorities for the county level analysis. The other direction that we're excited to take this work is to drill down to smaller geographic areas. So Jeff also described the work that we've done in collaboration with Public Health Seattle and King County, where we've analyzed life expectancy and cause-specific mortality rates at the census tract level. And what we find in that analysis is that the amount of variation that you see within King County is pretty comparable to the amount of variation that you see among counties in the US as a whole. And there's really no reason to expect that that's unique to King County. So similar to how we find that if you were to only look at the state level, that would mask important differences at the county level, we're also pretty sure that looking at the county level is missing important geographic differences at a finer geographic resolution. And finally, I'd like to conclude by just saying that I think one of the primary driving forces for all of us working on GBD is the strong belief that better, more detailed data allows us to make better decisions and improve health. And along the same lines, it's my belief that the more local and more specific that we can make these data, the more useful they are to communities and local leaders striving for a healthier future. Thank you.
Thank you very much. Thanks to the discussants and also to our main presenter for keeping to time. So that gives us about 20 minutes, 20 to 25 minutes for a question and answer session. So those of you who would like to put a question to the panel may identify themselves and then put it in the form of a question, not a statement. Yes, please.
Thank you, professors, for your share of knowledge with us. I am a PhD student from the Sun Yat-sen University in mainland China, and I have two specific questions concerning the localization of burden of disease study in China. And I would like to ask these two questions to Xiaofeng, right? And the first question is, during your talk, you mentioned your extensive collaboration between China CDC and the IHME, and as you know, IHME nowadays, they have turned to a more transparent role, which means that the part of their data and part of their methodologies have been or are being published for public access. And what do you think of the China CDC's role in the area of transparency? More specifically, do you think China CDCs have some plans on publishing data that can be accessible to all around the world? That's the first question.
Yeah.
Chinese, huh? You are right. So for China CDC, yeah, let me explain. China is a very good network in the CDC system, from national level down to provincial and prefecture or city level and the county level. So this network is quite, total is 200,000 staff working in this network. So major work of this net is just how to conduct the intervention and data collection and analysis and policy support for the different level of the government. Before, our major work is how to collect infectious disease data. And right now is the death cause is very important. So we select 605 counties like a pilot surveillance site for collect the data of the death cause. And then every 3 or 4 years, we conduct NCD factors and the nutrition investigation, just like a survey. So this data we can share. Also, right now, we just start to set up surveillance for the cardiovascular disease pilot surveillance site to collect data from the hospital for the cardiovascular cases. Just to start, this data still on the local. So those data, you're right, every year we collect and clean it and discuss with IHME. We have a MOU with the IHME to discuss what kind of data we can use and how to use. And then feedback for the China's government for future use and just like I mentioned for the 2030 of the health China. And many universities and institute in China, they asked us to how to share this data with you, like you raised this question. For our policy is transparency, and we can use, but sometimes is before we need to clean the data, and then we can share. So that's we discuss with issue with the Chris Marie, how to use data, and for the others, keep the balance for the local universities and outside like IHME. So that's if you have this willing, please contact with me for the future collaboration. Thank you very much.
Thank you. So you also mentioned the feedback of information to the government. So that sum up to my second questions. So my second question is, how do you actually translate the findings of the disease burden for China to the applicable policy, and how do you implement such policy under the condition of current Chinese governance systems? How do you collaborate? How do you put the findings in the disease burdens to a more generalized context so that the Chinese government will actually listen to your findings and they will actually make a change so that everyone lives better?
Yeah, you are right.
Thank you.
Thank you. The same questions for the Brazil and other countries. So how to use this data and the result, the impact for the policy makers. So for China, right now it's a very important period because we issued a document for, I mentioned, the Health China 2030, how to evaluate the progress. That's China CDC take this responsibility. So for the GBD, it's quite good model to how to collect more high quality data and publish this data very by the annually and by the what's the period is very important. Actually, for this time, Lancet already published the disease burden study 2016. We will translate very soon to and report writing this report to our government. So tomorrow morning I will have a meeting with the Chris Marie to discuss further details. And we hope this report can be very quickly to report to our lead. That name is the Health and the Family Planning Commission very soon. Thank you.
Yes, sir.
Thank you. My name is Bud Nicola. I'm University of Washington School of Public Health faculty and a member of the U.S. Public Health Accreditation Board. I'm really encouraged to see the development of subnational and particularly local county census tract kind of data that can be useful. I think I agree that this can be really useful in driving change and improving health. My question is, what's the best strategy for improving the capacity of all of our public health professionals working at the local and subnational levels?
Yeah. Marina, will you take the question? Local capacity, yeah.
But I think you probably can answer that question better than anyone else in the room. You know, it's a human capital issue. We need to invest in training the public health workforce, and we need to ensure that there are stable jobs when people finish their training. So as you know, we're pretty much dependent on federal resources for our chronic disease work in the US, and it's unstable, it's unpredictable, and it's inadequate. So I don't have the answer, but I do think that when we're talking about using data to inform policy work, I think that showing the magnitude of health loss and health disparities across the country can only serve to reinforce the need for a trained workforce to address that problem. And the other point I think I would make is that with healthcare transformation, such as it is occurring throughout the US to some degree or another, we're trying to integrate population health and clinical healthcare. And so in Washington State and other states, there are activities ongoing to try and integrate that population health perspective in healthcare system work. And so to the extent that that will be successful, I think we'll also have a new cadre of potential colleagues from the clinical workforce system that can pay attention to and address population health priorities.
Hi, this is working. I think the historical or conventional thinking about public health, what I'm trying to encourage is that it's about a much wider set of responsibilities. So it's the public's health with an apostrophe S rather than the discipline or profession expertise of the public health professional, but about how we get everyone, whether you're working in housing or employment or in social care, whether you're working in a hospital or you're working for the fire service or the police service, that you have an understanding about how health and what we mean by health, and how health is made a number of factors, healthcare only being one of them. In the UK context, we have had fabulous progress in the last 30, 40 and 50 years, but it has been very much a biomedical model, and it's been very much looking into healthcare. I mean, huge improvements in better survival rates from cancer and vaccination rates, as good as they've ever been. But what we haven't been is working with that wider workforce and recognising that wider workforce and the contribution that they make. So the police service in the UK spends 70% of the time, and increasing, dealing with mental health problems that folk are facing. The fire service in Greater Manchester is a first responder for cardiac events. What we're doing is widening this understanding of what we mean by the workforce, and investing in a much deeper and broader understanding of what we most want people to understand. We think that there's a really great opportunity to get an understanding of GBD into curriculum at under and postgraduate level, and to get it into the narrative, not just in health, conventional health-related disciplines, but into teaching about this, and that health is about a whole lot more than healthcare. And if you're an economist, you've got a fabulous contribution to make. If you're an accountant, make a difference here as well. So certainly for the public health workforce, as we've always understood it, we of course need to keep investing. We need to produce people and train people and give them exposure in our own countries and around the world. We are going to need the future Peter Piots. These are folk that are an essential part of our future. But if we're really going to make the shift that we all want to see, we need to think about this in a much broader way.
Yeah, thank you.
My name is Nomonde from the Embassy of South Africa in Washington. It's encouraging to see these experiences and examples from local level work of the GBD. It seems now that the stars are aligned for increased geographic granularity of GBD work. And South Africa is one of the countries that needs it most, in fact. I've been thinking about the most strategic entry point for IHME in terms of informing policymakers and political decision makers as we take this GBD work to a lower or a most important granular level geographically. But BRICS, if you talk BRICS, for instance, emerging economies, Brazil is in. I'm not so sure about Russia. India is in. South Africa is in. China is in. Then what we only need to do is to speak to the political decision makers. There's a group of health ministers of the BRICS that need to understand the usefulness and the importance of GBD. And within that context, you can expand to finance ministers and you take it up a level to presidential level. So I'm thinking strategic entry point at the level of the BRICS. There's no question that the geographic granularity is necessary. But for emerging economies, that entry point of the BRICS is important. of course, globally. Thank you.
Okay. Yeah, who would like to take the question?
Yeah, I totally agree. I believe we have to connect because it's together that we get more power. So we could advocate with BRICS countries and GBD for BRICS countries because we all have subnational analysis and we could strengthen our knowledge, what is common, what can we do together, like for change behaviors. Because it's not exactly a destiny. We have in Brazil a region that is has what we could call late transition, but in fact, why should this region make a transition for chronic disease? Why not start to switch in the behaviors now, so they cannot have the same process the others? Because we have improved and dropped in the whole world, even in our countries, the group 1, infectious disease, maternal and infants, and malnutrition. But violence and chronic disease are increasing. So should it be a destiny for everyone? Have the same transition? Why not do something now when we can do with population that's not have this kind of transition? So that's the time for our action. We should do more because we are countries or technicians or people, they are working in a country in health services. So we can do more, much more than we have been doing. And it's important, I agree that it's important to drive our attention, our actions, using information, using analysis, but it's not enough. We use it, but it's together that we'll get better results and get a better health for our population and reduce inequalities. That's our goal, to have a better world, not just one good country, but all countries together. I agree totally, and we could start our work soon. No? Thank you.
So I'll be brief. I think at national level, what we're trying to do is make it an economic argument and showing the relationship between paying attention to the burden of disease and the drain or constraint that has on the economic performance of the country and where the opportunities are to do better there. At a local level, it's all about the people living in a place, not a condition or a disease or a risk factor, but about people living lives and about where the opportunity lies and where you can make the biggest difference. To give you a quick example, using the subnational data, we produced local profiles of health for every part of the country. And the headline in the Manchester edition of the Times the next day was "Visit Manchester and Die." And this upset Manchester. And it's a very competitive thing. If you can show people in language they understand, not the language of and factor, but in language that says you do realize that the number of folk that smoke is at a factor of 3 or 4 greater than at that place down the road, and here are things you can do about it, does make a difference, but it's got to be local. But if you're talking nationally, I'm fine. You've got to show how to get the money, how this helps with getting the money right.
Thank you.
Chris Murray. So this is a question for Duncan and anybody else who wants to chime in. But England, China, Mexico were the first wave of subnational assessments, and now you're the very first that has pushed the analysis for the whole burden of disease down to these upper tier local authorities or second administrative unit.
Yeah.
And I think it would be really interesting to hear your vision about how that's going to be communicated down to local, the people working in upper tier local authorities, and what's the way you think that that'll have the most impact and use as that starts to be released?
Yeah, I know I need to be very brief. We believe with a passion about transparency and just getting information out there and to the people that can make use of it. So at a local level, since 2013, local government at that level have had the duty to improve the health of the people. Now, they last had this duty in the 1970s, and it was taken from them and given to the NHS. Time doesn't allow, but it was returned to local government in 2013. And their duty isn't to provide a public health service, but to improve the health of the people. Trying to get is data and information to them that enable them to make the decisions, the policy decisions, about all the interrelated factors from a good start to life, through education, through employment, into old age, and about how they can use this at a very local level to make those judgments and choices. There is, of course, a national infrastructure or framework from which we all operate, but most of the decisions that affect local people, a decent education and a decent home and a decent place to live, are local decisions. So this is aimed primarily at the chief executives of these upper tier local authorities and the political leadership. It's naked, it's directed to the decision makers. It is not directed to the researchers, the scientists, and the broader scientific community. It's directed at the decision makers, and we're going to be holding them and ourselves to account for what difference this makes over the next 5, 10, and 15 years.
Thank you.
And at heart and centre of that is the GBD.
Okay.
Brooks, Centre for Health Policy at the University of Melbourne. I think this question is probably directed at you, Duncan. You've talked a lot about, we've talked about the Human Capital Project. We've talked about the issues of educating workers, but shouldn't we be pushing it down a little further? I think this is what you might be trying to do, but we haven't heard all that much in this meeting about the patients.
Yeah.
And all around the world, we're talking, as clinicians, we talk about patient participation in clinical decision making, all this sort of stuff. We've got to get this stuff out there. We've got this little machine here which allows us to do that. And I just wonder whether you'd like to comment on that and how new technologies might actually drive real decision making and responsibility at an individual level to keep myself fit.
Yeah, that's such a great question. I'm convinced that the future for infectious diseases is software engineering and mathematics. For everything else, it's behavioural science. And what we're seeking to do is to differentiate between a risk and a hazard, and about the giving of information to people, or getting information in a trustworthy way to people, for them to be able to make a broader set of choices, and hopefully more healthier choices. But that's quite different from how do you get people to change behaviour. And we're on a journey about how to, and we're not entirely sure how you do that. We've got a whole series of pilots and projects and initiatives that we've got underway, but we're giving a really hard bit of think at the moment to how do we both get information to people that allow them to make those choices at an individual level, and at the same time to get a movement going about behavioural change, some disruptive technologies like an e-cigarette, but lots of other ways to think about this. So in the five ways that we look at the world, there's international, because we live in a global context. There's government, about how do you get big policy decisions taken that you think will make a difference. There's local government, which we focused on a lot. There's the NHS itself and our context, but how do you help the healthcare system make better choices about how they spend their money, and crucially, there's direct to the public and the individual responsibility, and about how do you help them reach them in ways that are more meaningful and relevant to them. So this year, last year we did everything on quitting smoking using Facebook. We did it for 20% of the cost, and we reached 75% of the people in the income classes that we most wanted to reach that's still smoking. Using new technologies, using new platforms, reaching to individual responsibility.
Thank you. I think we have run out of time, except maybe last question, unless there is a very compelling question needing a compelling answer.
Well,
yes, last one.
Salim Yusuf, Canada and India. Most of you on the panel represent countries that are already good. There is good in health information, good at least national statistics, and many of you, like the UK or Canada, and even China has good county-level statistics. I've seen maps of disease from China for the last 30 years. That's great. What we heard from our colleague from King County is, in order to go further down, one of the richest countries in the world needs extra support. You represent the minority of the world. I'm going to ask Dr. Rao, who represents one of the biggest countries in the world, which has one of the poorest health statistics. Is this thrust towards subnational and county-level data going to increase the disparities in health information between the rich nations and the poor? The low-middle-income countries and the low-income countries barely have good national data, let alone state-level data, and practically unreliable risk factor data. So perhaps the discussion shouldn't be how much more wonderful it's going to be for the rich countries, and that includes my Canadian hat, but it should be more with my Indian hat, which is what can we do to bring up the level of data from the poorer countries, the low middle and the low income countries. And I'd invite the chair, who has the national leadership role, in how you envisage the low income and the low middle income countries having better data.
Would you like to respond?
Thinking of India.
As a moderator, I'm not supposed to.
I'd like to make a comment.
Well, I think anyway, I will wind up also. Thanks very much again. You see, when we look at global disease burden studies, it's a very intellectually stimulating exercise for many of you who are modelers, who are researchers. But the moment you bring it to the local level, I think it's a different ballgame altogether. I think that way, this session is more useful to those of you who are from the IHME or who are the collaborators who are working on these projects, because you need to look at in a totally different angle when you take this data to the local level. As it was brought out by Duncan as well as Maria and then Prasada, they understand a different language. They speak a different language. They are politicians, they are local body officials, they are bureaucrats. It's not that they are foolish, they are very intelligent people, but they need a different type of communication altogether. So the way you project your data, the way you project your information to them, which makes it appealing to see that they are weirded out to take certain concerted action. I think that is what is important. That has come out very clearly in this session. Maybe we have already launched 2 or 3 subnational estimates. We're going to do it in India. I think some of the questions that you have raised becomes very relevant there for a discussion. I think it has been a very stimulating discussion for me. And I think we need to see how these new skills can be acquired and integrated into the work that GBT IHME is doing in the GBT. And maybe we need to have some discussion on this maybe in our next meeting of the Independent Advisory Committee, Chris. So I think that way, thanks once again. You want to say something? Yeah, okay.
Because I believe in Brazil we have exactly the poor areas and poor regions where we don't have good information. So the investment in improving systems, collecting data, and collecting as well as having household surveys, but improve administrative systems, it's a hard work. There is no miracle. There is no kind of pill that I take, and suddenly everything gets better. It's a hard work. Requires commitment, persistency in improving. So you go one by one, community by community. There is no way, because if you go, you have until a certain level, no, 70%, 80%, but you will miss exactly your priorities. And where is the problem, the most important problems for poor population is exactly where I don't have information. So I have to go one by one. That's the only way to improve. Or you just miss this part of your population and you keep it the other part. So that's it. Thank you.
Okay, great. I think the message from this session is you have to go global to local, information to implementation. I think that is the message. Thanks a lot.
Thank you. The comments are excellent. Would you be willing to share anything specifically? I think they summarize a lot of really good